Okay, so welcome everyone to the February AT Jousse Lecture. And once again, a reminder that the previous lectures for this series are posted on the Kite YouTube page, where you'll be able to find the past talks. I'd like to welcome everyone, especially if this is your first time here, a special welcome to you. We have monthly presentations, and definitely feel free to text me in the chat or email me afterwards if you'd like to receive announcements for future talks. We're delighted today to have Dr. YuYing Chen speak to us. Dr. Chen is a tenured professor and a vice chair of research in the Department of Physical Medicine and Rehabilitation at the University of Alabama in Birmingham. She received her medical education and PM&R residency training in Taiwan and subsequently earned a Master of Public Health degree at Yale University and a PhD in epidemiology at the University of Alabama. She presently serves as the project director of the National Institute of Disability, Independent Living, and Rehabilitation Research funded National Spinal Cord Injury Statistical Center that directs and manages the National Spinal Cord Injury Model Systems database. Dr. Chen's research focuses on epidemiology, mortality, and secondary complications or secondary conditions after spinal cord injury, and has published over 90 manuscripts in peer-reviewed journals. To promote the use of data from the Spinal Cord Injury Model Systems database for rigorous research, Dr. Chen has also provided methodological consultation and assistance to investigators worldwide. Dr. Chen's a member of the editorial board of the Topics in Spinal Cord Rehabilitation, the journal, an oversight committee of the NIH SCI Common Data Elements, the International SCI Data Set, and ISCOS Prevention Committee. It's quite a lot of hats to fill there. And so I'm very delighted that she took some time today to present to us a talk entitled Changing Trends in Spinal Cord Injury in the COVID-19 Era, the findings from the United States Spinal Cord Injury Model Systems database. If you have questions, Dr. Chen is welcoming to allow you to ask questions at any time during the talk. But we also will have time afterwards for a short Q&A. So feel free to either raise your hand or to type your question in the chat, and I will be happy to read it for you. Okay, so with that, I'd like to pass it on to Dr. Chen for today's talk.
Thank you, Brian, for the invitation and also, that very nice and sweet introduction. So I'll go ahead, share my screen. Okay, then I'll start. Okay, can you see my screen okay? Great. So I really appreciate the opportunity, to meet you all, virtually, and also give you update on the trends for traumatic spinal cord injury. This is something I'll say we found it kind of incidentally, when we analyze the data from the model system database in preparation for the annual report. So I'm very excited to share our finding with you today. So before I start, just welcome you all to my office here. So I'm in the office. As Brian said earlier, I'm with the Department of PMR at the University of Alabama at Birmingham. We call ourselves UAB. It's located in Birmingham, Alabama in the United States. So exciting news to share. You can see we are building a new rehab hospital to be open soon. So it's very exciting. It just kind of, behind my current building, kind of outside my window. So if you hear any noises, you know what they are about. And I apologize for that. But hopefully, it won't be too much distraction for the presentations today. So my presentation will be a little bit more data focused today. But we all love data, right? You know, we need data. We need data to justify what we are doing, right? Why we study these topics, right? Why this is important. You know, you need data to support your work. You know, why I focus on this particular group. I do this intervention for this factor, risk factor, or protective factor. So I think everything need to start with epidemiology, need to start with some data. So I think that's the reason, you know, the article I published in Archives of PMR in 2016 focused on the trend for traumatic spinal injury was, you know, named the most cited article in 5 years. So I'm very proud of that, and I'm very happy that people do kind of read through, understand the trends, you know, before they do their work. So let's go ahead, start it here. So what I plan to do for the next about, you know, maybe 35 minutes, I'm going to tell you more about the model system program and database in the US, particularly the spinal cord injury model system database. Then I'll use the data from that database to give you an overall trends for traumatic spinal cord injury in the demographic and injury profile over the last 5 decades. Then we will kind of more focus on more recent, you know, recent emerging trend and what kind of implication for clinical care and research. So you probably heard about model system databases. So put it into words. It's kind of as a prospective, longitudinal, multi-center study focused on the longitudinal course and outcome of catastrophic injury after a coordinated system of care in acute trauma and inpatient rehab. So sounds like a demonstration project, you know, to begin with. So these model systems program were funded by NIDAR, National Institute on Disability, Independent Living and Rehab Research. It's not part of MIH, but it's under the Department of Health Human Services, under the same umbrella as MIH, but NIDAR is not part of MIH. So it's under the Administration for Community Living, ACL. So the good news is that all the model system database data have a public version data set are freely available for download and for research. Just, you know, make sure you are aware of that. So these are the 3 model system program and databases funded by NIDAR. The first one since 1970, that's the Spinal Cord Injury Model System Program and Database. So it's a competition. It's a federal funding. So the current 5-year cycle go from 2021 to 2026. There are 18 centers fully funded and 4 follow-up centers, you know, collecting data for the database currently. And there is 1 national spinal cord injury statistical center, which is located at UAB, and I'm the PI for that center. Then there's a traumatic brain injury model system program and database. They started a little bit later. It's in 1987. So 5-year cycle go from 2022 to 2027. Currently, they have 16 center and 3 follow-up center. And the National Data and Statistical Center is located at the Craig Hospital in Denver, Colorado. So the youngest is the Burn model system. They started in 1994. They are much smaller. So they only have 4 centers in the current 5-year cycle. And the National Data and Statistical Center is located at University of Washington in Seattle. So these 3 programs and have to work with so-called MSKTC, Model System Knowledge Translation Center, to develop material for the community outreach. So the MSKTC is located in Washington, D.C. It's the AIR. I believe the name's American Institute for Research. So more about the SCIMS database, SCI model system database. So as I say, this program started in 1970. So by end of this funding cycle, we'll have total 32 SCIMS centers have been designated across 21 states, and including District of Columbia. And in terms of the database, it did not start in 1970. It started in 1975. Took a little bit for the center to figure out, to get on board. So when they started the database, there were 10 centers. And they decided to retrospectively enroll participants to the database back to 1973. And then 31 out of the 32 SCIMS centers have contributed data to the database at some point. And the national, as I said, UAB is the National Data and Statistical Center. We started this center designation in 1983. So as I said, purpose originally sounds like more like a demonstration project, right? To demonstrate the continuity of care, comprehensive multidisciplinary care system. But now, 50 years later, this concept has been widely accepted, globally. But the database still exists. So we kind of transform the objective into more research and knowledge translation. These are three key area. One is study the trends over time, just like I'm here today. Who get traumatic SCI, how they get it, what caused it, what kind of outcome. So that can be used for prevention, for healthcare needs projection. And also we follow them up. We just not enroll them. We follow them up over time. So it provide an opportunity to understand their longitudinal course, right? Their physical, psychosocial well-being, even how long can they live, cost of care. So this definitely information will help us continue to serve them, provide the rehab standard, best practice, or even inform policy. And the third purpose is great, right? It's become an infrastructure. We have center come together. We meet every 6 months. So we have a lot of collaboration going on among centers. So database is one requirement for the model system. The second requirement is also a module project too. We have to collaborate on different research projects. So you probably already know we collect data, at the beginning, the initial hospital care, we call it Phone 1 data set. And we also follow up on then we call it Phone 2 data set. So currently the follow-up schedule is 1 year, 5 year, and every 5 year until the participant disease or withdrawal consent or recovery. We used to do annually, but just because the build up the workload, and we just don't have enough resources to do every year. So we compromise now, it's just every 5 year. So I need to move a little fast. In terms of how big is the database, so as last year, August, what we do the data submission twice a year. We call data submission, it means that we set a deadline twice a year, enter all the data in, we'll run a quality check, then we'll make the data available for research and report. So as last August, we have Phone 1, we have close to 70,000 Phone 1 participants enrolled in the database. In terms of follow-up record, these are all successful follow-up, useful information. We have more than 132,000, follow-up record. And then registry, I did not say much about registry. It's just people who are not quite qualified for Phone 1, but we also collect some basic information on them, and they are not being followed over time. We started this in 1986, mainly just for the purpose to understand, what Phone 1 represent. Can get additional information about the representation of our database participants. So at the footnote there, you see our longest follow-up is 50 years. We have one at a time, and we have 276 participants have 45-year follow-up data. And the right side of the table just kind of give you idea about what's the current status of those, Form 1 participant. As you can see, about 1/3 of them already deceased. About 12, 11% of people just not eligible follow-up because they withdraw consent, they will recover, at some point. And unfortunately, we have some participants just that the center lost their identifying information because the break in funding or different reason just not able to re-identify them. Some of them just 50 years ago, the leadership change over time. So that's unfortunately. So we have more than about 50% of these Form 1 participants still eligible for follow-up, and we still keep to find them if they were lost, even the recent follow-up, but they are still eligible for continued follow-up when the next Form 2 due. So the database continue to grow. Just remind you, we are still continue to enroll and follow up the current 5-year cycle. As mentioned, we have 18 fully funded center and full follow-up center. Full follow-up center is mean that they were not fully funded by NIDA, but they were funded by the data center. NIDA set aside some fund for us, try to reach out for those defunded center and try to get them continue follow their participants. So the growth rate is about, we enroll about 1,100 new participants every year. We follow up about 2,500 every year. What information we collected, we really try hard to map out the ICF model, the International Classification of Functional Disability and Health. So we cover body function and structures, their medical complication, their health condition, bladder, bowel, activity. We use Sci-Fi 80 as SCI functional index, care, which is the replacement for film. Participation, we still use chart, and we have some psych-qual major as well, education, employment. We collect a lot of contextual factors covering environmental factor, where they live, their access to different technology, and some insurance, access to care. And we also collect personal factor as well. So the source of data, medical record review is the main source, especially for Form 1. And we require direct physical exam for neural exam and body weight measurements. And then most of the data are from the cell report, for different reasons. Well, definitely is nothing about us without us. We want to hear from them, from their voice. Definitely is also for convenience. And the follow-up just easier to reach out and to get them respond. Ask them to coming back to the clinic. It's sometimes it's quite challenging. And death records. We do link to the death record for study mortality and survival. And we have a lot of quality control in place to make sure the data is good, reliable for research. Definitely SOP training, and each center required to do some quality improvement every 6 months. We kind of generate a list of random samples, say, hey, go ahead, do re-abstraction, call them back to see if they been called, it's not fabrication of data. And we monitor the follow-up rate, enrollment rate, missing data rate every 6 months. In this website system, we build in different quality control error check as well. And for reinforcement, we do certification, we do site visit. We ask them to have a management plan if they did not match the benchmark, and they had to share the plan with their NIDA project officer. The data committee meet quarterly, and project director and our NIDA officer meet biannually in person, to discuss, review, and maybe refine some quality measures. Data is available for download. It's on our website. Currently, we put out 2 versions there. The most recent version is all the data collected by August 2021. The other version is 2016 version. So we put them both there. It's because some variable may exist in one version, but not the other. Just because we do change the information every 5 years. Information we collected every 5 years. So the information on the website, to help you understand the database. Even we have a list of publications so you can see what topic have been started. And definitely data collection form over the year, data dictionary, and we give out award too. And also the annual statistical report can help you to see the distribution of data, maybe have a good estimate of the potential sample size for your project. So I just kind of put this out. We have the Vivo Mentor Research Award. We encourage trainees, could be pre-doctoral, postdoctoral level, even resident, who propose to use the data for their research. We give out $3,000. It's not much, but hopefully enough for they to travel to present. The requirement is very minimal. You just have to be secondary data research using our data and also have mentors commitment. More detail on the website, or just email me. So in summary, as you can see, the strengths of the database is a longitudinal, long history, relatively large sample size, and geographic and participant diverse. It's an excellent case identification procedure. We do have guidelines to follow, not just convenience sample or not just medical record, a lot of missing. And we have standardized data collection method and measures, and we have multiple level QC check. But definitely there's a limitation, right? The scope of the sample, representation will only be able to enroll people who treated at the model system, not everybody. So it's a hospital-based sample. It's not a population registry. So it's not appropriate for estimating the incidence rate or prevalence rate or any population estimate. Definitely longitudinal is the beauty of the database, but there's lots to follow-up issue too. Also, as I said, it's longitudinal, but something change over time, and we just need to change. Eligibility criteria change a little bit, but not much, because this is competition. Model system size can vary every 5 years. And we review the variable and make a revision, kind of say, hey, internet become, digital divide become an issue. We should gather that kind of information, social determinant of health. So we do make changes to the database in terms of what information we collect. But I will say that just have the understanding how the data are being collected or analyzed, or even over time. We see the database still very valuable in advance our knowledge in rehab. And also the relevant to your research, healthcare provider and policymaker too. And really these days, the social media, the misinformation, we see ourselves as a trusted information source. We definitely, thrive to provide a reliable and trustworthy information to people with SCI, their family member, or whoever interested in this topic area. Okay, I can pause a little bit to see if there's any questions so far about the model system database.
So if you have any questions, feel free to raise your hand or even type it in the chat before we move on to the next section of the talk. Dr. Craven, has her hand up. Kathy. Oh, you're on mute.
Apologies. Thanks for your presentation. Can you share with us the focus of the next model systems cycle? What's new or been added in the newest funding cycle?
So the newest will be 2026, right? So we haven't have any words yet. But I can tell you, so that's a good question, Dr. Craven. You may already heard, some of you may already heard, Neidler had put out supplements, last year and this year. So that's second year now. So, the Neidler director, Dr. Angeli Fober-Bush, not Fober-Bush, Fober-Pratt, she's very passionate about non-traumatic spinal cord injury. So she managed to find additional funding for model system and encourage us to do non-traumatic. So we quickly put together, so we did a pilot on phone one, that's our first year. So we did, and we set up we set up the guideline, definition, classification, and we require each center to enroll at least, I believe, 10 non-traumatic, kind of as a pilot. So Neither happy about that, give us additional funding. So we are now piloting the phone two follow-up. So it's a good question. We are definitely on our radar to see what the requirement for the new cycle will non-traumatic become one part of that database. So it's exciting, but challenging too, as you can imagine.
Yeah, certainly here in Canada, we're seeing a rising prevalence of non-traumatic spinal cord injury. It's about 60% of who we admit and provide care for, and having a consensus about what we should actually measure and track for that group be really great. And we continue to have conversations across the country about the oncology subgroup as well.
Yeah.
The non-traumatic. So just interested in what you're doing there.
Yeah, I'm definitely the person pro for that. I feel data model system have been there for 50 years, but we leave out a very significant group of people who need help, need care. But as you can imagine, there's a resistance as well. There's a reluctance in the group as well. They just feel they are two different groups, So yeah, we'll find a balance.
Yeah, thank you.
Thank you. And there's also one question in the chat from Dr. Walden. Is there an information document on the measures in the databases, which I think you mentioned there's data dictionaries available?
Right. It's on the website. Yeah, but if you want something, email me too. Otherwise, yeah, you can find it from the website.
Yes, and I hope that answers your question. Thank you. Okay. So
okay, I'll go ahead talk about the trends. So I'll kind of give an overall pattern, through 2000, based on the paper I published in 2016, and also supplement with information with our annual report, more recent annual report. So I don't think you need me to emphasize how important to understand the trend is, right? You document it, you identify the target population for prevention and who needs care, and make sure you prepare for that. So this is database. So we cut off at all the injury happened, by December 31st, 2022. So we divided them into a 7 injury cohort. Earlier injury cohort, we used 10 years as a group. More recent, we have 5 years, 2010 to 2014, 2015, 2019, and recent 2 years, kind of during the COVID or post-COVID a little bit. So on the lab, you can see our inclusion criteria for the traumatic. And this is the US population from 1970 to 2019. So it's aging, right? I'm sure it's a similar pattern to the Canadian population. Average age on the left from 28 years old to 38. That's just the general population. When you go out to the store, what's the average age you see? And a figure on the right is the percentage of people, the aging population, as we we use 65, age 65 as a cutoff from about 10% to currently to 16% in 2017. We use 2017 data because that's the mid-year in that 5-year. So this is the SCI population. So the red line is SCI population. So you can see, looks like the new traumatic SCI average age is aging quicker than the general population, right? From 29%, in 1970 to now is about 43 years old in terms of average age. In terms of percent of 65 and older, from 3% to now about 16%. So you can see, okay, the aging is faster in terms of people getting spinal cord injury. So that's kind of go back to my epidemiology bathtub. That's what we said, right? You have water coming down from the general population, who get that disease, who survive, or who still having a disease become prevalent cases. And if they die or they recover, they go out of the pool, right, the bathtub. So you are thinking, the change over time here, that's our general population coming to our SCI population. If their rates are about the same over time, across age group, you should see a pretty much parallel trends there, but it's not the case. So this is another research I can give you a little bit hint. This is Dr. Jane's research using trauma data. So that's kind of 1993 for male. Probably that's something we know most, right? It's a bimodal. We always say the first pit is like a late teen, early 20s. And the other pit is when you get really old. That's kind of the pit, the risk, higher risk, highest risk. That's 1993. So female, just much lower risk than male. That's for sure. And their younger age group is, much lower as well. But the higher, when you get older, you have a higher risk, but not as much as male. This is the 2012. Still is 10 years old data already. And you can see, from gray go to blue, you can see the younger age group, the risk drop, so one message is that we did pretty well in terms of prevention of SCI in the younger age group. Maybe it's we emphasize, right? Late teen, early 20, or even, that age group. But the older group, their risk kind of higher than in the past. Definitely we can throw out theory there, hypothesis there, could be they are more active, they do more high risk taking behavior, different reason. And female kind of similar pattern as well in terms of improvement in the younger age group, but the older age group kind of climb up. All right, so a little bit more aging stuff. So the aging phenomenon, kind of cross different race, sex, especially in the Y male and Y female. Not so much on Black male. The average age in 2017 about is still below 40. They are younger age group than other race. Black male. Same thing for Hispanic male, they are younger. That probably contributed by different etiology. Talking about etiology, right? So for the aging phenomenon can be seen for different etiology as well, right? Vehicular accident, falls, violence is relative just about that age group, still is just the behavior driven is like, average below 30. Sports, even sport age increase as well. We are a little bit different is that we also define medical surgical complication as traumatic spinal cord injury. That's kind of more old CDC definition or external cause injury ICD code. So we have that group in the database. So that's just the aging phenomenon I like to share with you. Male-female ratio in the general population is pretty equal, but as you know, in the SCI population, majority is male. And we see the percentage of female have a little bit increased recently over the last probably 2-3 decades. So that's the race, ethnicity composition for the SCI population in the database. It's a little bit more challenging to interpret just because, a lot of just depends on geographic area, so it's a little bit challenging to make a reliable conclusion. But overall, you can see, I use the US 2010 as a reference. You can see our Black SCI is much higher than the US population in terms of percentage. I think that's because they have a higher risk of getting SCI than other race. And we see the Hispanic increase from 1970 to 2019. That's just kind of US general population, more Asian, more minority. But we definitely not well represent Asian or other race just because the eligibility criteria, right? We cannot speak their language, so we did not enroll them. So that's why I say race ethnicity is a little bit more difficult, complicated to interpret it. So I move a little bit fast here. So that's our etiology trend, probably not surprise to you. So vehicle accident still the majority, the blue line here still is the leading, but down from 46 to 38. And you see the fall, the red line continue to increase pretty consistently. And that's the level injury. You look at C1, C4, the high cervical, the red line, kind of increase over time. Used to be, 14%. Now is the majority. Not necessarily majority. The most common one is C1, C4, 34%. And C1, C4 plus C5, C8. So that's the tetraplegia is the majority, more than half tetraplegic. Definitely kind of parallel the trend of fall injury as well. That's the AIS. You see, complete injury used to be the majority. Now it's about 1/3, the purple line. And you see the red line is the D is kind of increasing over the last about 4 decades. So the implication, right? Aging, definitely have a challenging to the care, right? Pre-existing condition, the cognitive difficulty become an issue because we all think SCI brain usually is fine. Now, because the aging cognition could be a factor to be considered for the care, even for the rehab. Pet personal care assistant needs, lifetime costs, definitely prevention for etiology and aging. So I'm going to jump into the more recent finding. So as I said, it's just something we found when we analyzed the data. I thought everything will be just going this way, going that way, pretty consistent, but just it's interesting, not what I expect. So this is the age injury, that's the average age. So again, the blue line is the general population. It still continues slowly, increase even the recent 2 years. But our SCI population, at least from the database, we did not see the increase, still 43. So that's the first kind of interesting finding. But I look at how about aging, 65 years and older. Oh, they could still continue to climb up, from the recent 2 years from 16% to 17%, just kind of parallel to the general population, nicely. So kind of that means that, okay, elderly still, a lot, kind of pretty steady. We got a lot of, we still got elderly have risk of spinal cord injury and come to the rehab. But the average age kind of not increase. So maybe we have more younger here, right? So the average out kind of stay the same, although you elderly kind of increase. So how about male female ratio? Earlier we see increase in the female, recently, but kind of down recent 2 years. We have more male patient in the database lately. So again, this is maybe a little bit challenging to interpret it just because so many factors play into this, but at least I think the Hispanic, stood out, from 13% to 17%. Even partially could be due to the center composition change. As I said, the new cycle starting September 2021, we have new center join. So that may have some impact on this, but still 13 to 17 is quite, significant. Okay, I want to show you the etiology of injury, right? So, vehicular still the top, but you see the down now. And the fall come to increase, but no, I thought it will be continue to increase or just stay there, but it's down now. But violence increase, from 14% to 18%. So that kind of made me thinking, well, yes, I should not be surprised, right? Because, so much going on, in this country lately. And so I kind of look at male, female, you thought that will be more male things, but even female, right? We see the jump, in terms of violence etiology. Now it's 11% of all the injury are caused by violence. Used to be, 3 years ago is 7%. Now it's 11, 12%, for the female. The fall kind of stayed there. Male, increase as well. Definitely it's more common in male a little bit. It's about 20% of all the injury due to violence. It's kind of high. It was not the case in the past, from 16 to 20. So I did not do the racial differences. I think that would be very interesting to see as well. So that's level injury, averagely, overall, C1, C4 still the most common and pop about stay there. But male, female is, if you look at female closely, the paraplegia increase, from 30% 3 years ago to now 37%. And then, so because they share the pie, right? 100% pie. So C1, C4 is down. So now the most common for female, at least over the last 2 years, is the paraplegic, 37%. Male is not that kind of dramatic as female. But you don't see the C1, C4 high tetra continue to increase. So that's completeness of injury, not much changes here. But if you look at female, they have more complete now. The purple line is complete, right? From 26% to 31%. So that what means that we see more complete para for female lately. So this is probably, driven by violence, driven by gunshot wound. Possible because it usually is a thoracic complete. But that need further, investigation analysis. For male, similar but not as, dramatic as female. So as I say earlier, because, we have center changes over time. So I did quickly look at some subgroup analysis, focus on 6 model system center as well. Only these are center have been continue funded throughout the 5 decades. So I look at them, I kind of confirm the trends in the increasing violent etiology here from 14% to 18%. So definitely this is alarm, at least need further investigation. Did this parallel the trend in gun violence in US? I'll say yes, but definitely we want to gather more data, to look at more in depth. And now the demographic injury profile changed a little bit recently. Well, this, when you do the follow-up, you may see a different pattern as well in terms of their well-being, could be influenced by the, the population here. And again, we need more analysis to confirm the trend and to see it just because artificial effect or really something we need to pay attention and do some intervention. So the theory will be, COVID pandemic, social political unrest, financial hardship definitely play a role in violence issue, especially in this country. And definitely, when this prevention should be very, should be flexible, right? Depends on what happened in the environment, what happened in the society. We need to be very responsive, for prevention or even care as well. So study limitation, definitely we need to interpret this data very carefully. One is generalizability, right? This is this finding can speak for the entire SCI population in the US or not? We definitely want to be very cautious to look at different angle to make a assumption, make a conclusion. And just because we are hospital-based, we tend to be in more urban center, treat a lot of trauma, violence as well. We will kind of just be misleading. We need to be very careful about that. And also, as I said, this is hospital-based. We can only do percentage. We don't really have a good denominator to do the incidence. So that's be careful, if they share a pie there, one increase, the other decrease, not necessarily reflect the incidence rate here. But as long as we be very cautious, I feel the estimate is still relevant for research and for clinical care, even policy. So I definitely should acknowledge NIDA for their continued generous support for this model system program. And my model system colleague on the right, that's the first time we do the in-person meeting after COVID. So that's much smaller group in Washington, D.C. And the picture on the left is my team, data center team. So that is my email there. Just send me an email if you want to know more about the database or have any question. So, all right, any question? I think we got about 5 minutes here.
Yes, thank you very much. That was a great presentation. And I do open up time here for any questions that you may have. Feel free to either raise your hand or you can even type the question on the chat if you like. So while people are waiting and doing that, I guess one question I did have, I think you mentioned it briefly, but I just want to get more information on it. You mentioned that maybe one of the limitations of the data itself when it deals with different racial groups is that they will need to speak English to be able to participate. Is that what I think I heard, or is it available in different languages so that people who, let's say, speak Spanish or as a
right? So I know this just kind of I think it's more IRB issue. So we feel good. We feel confident that we are good at recruiting, enrolling English speaking and Spanish speaking. But for other language, maybe Chinese, Dutch, it's just because one is this nobody can speak in-house. The second requirement is, but for that, we can accommodate that. We always have services in the hospital. But another requirement is challenging is that you got to have the informed consent in their language. So that's kind of just it just doesn't work, for most of the centers. So that's why I say we may miss them. Definitely sometimes Hispanic, it's just the illegal immigrants. They may tend not to enroll them because they cannot pay them. For this program, we do have some compensation. So it's just some little thing here, there, so make that kind of complicated. But we feel good about, English speaking and likely Spanish speaking as well.
Interesting.
Mm-hmm.
So open for any other questions that people may have as well.
Yeah, I'd like to know if you see the similar trend or you expect to see the similar trend in your Canadian population, or you have any suggestion for me to do more analysis. I'm welcoming any suggestion.
So we have a multi-center quality improvement project that we have been leading, and the mean age of spinal cord injury has gone up more than 10 years in the last 3. So we're certainly seeing the rise in the age of onset of spinal cord injury, and certainly experiencing the admitting patients with medical comorbidities. I was interested in knowing what comorbidity scales you think are useful for the SCI community based on your experience and thoughts from the center at UAB there.
Right. So I have to admit, we don't have a good comorbidity measurement in the database yet. So last time, what we did as a group is that we look into Medicare, different more aging-focused research to see what's the most common issue. So we include some of the information in the database, like hypertension, hyperlipidemia, fall, sleep. Still not perfect, But a lot of reasons because we're just trying not to burn out our study participants,
Right.
try to be limited. So it's a challenging, it's a balance act.
Mm-hmm. And do you capture like service interruptions or people being discharged out in the data set now?
So yes or no? Yes, it's very limited. We do have patients have short-term discharge. They haven't completed, they go back to the acute for different surgery. We have that there.
Yeah.
Yeah, probably not very helpful information.
Okay. Well, I just want to say, as a Canadian who always looks to UAB for credible data, we really appreciate that you exist and do analyze what you do have. So thank you.
Yeah, I welcome any feedback whenever you have any feedback. So that will be helpful because we always try to justify we are good, we are important. So neither keep supporting us, Yeah, so some selfish reason. Thank you.
Thank you. And Dr. Noonan has her hand up.
Thank you. And thank you, YuYing, for a wonderful presentation. And similar to what Kathy said for the quality improvement work in the Rick Hansen Spinal Cord Injury Registries, for our Canadian database, certainly see similar trends. Really is this growth in the falls and our vehicle accidents remaining, crashes remaining fairly stable. The question I had for you as we move forward with maybe in Canada, we're just getting to the rollout of the electronic health records and Epic and Cerner. Just wondering what % of your data, if you're seeing a shift to your data collection being pulled from these electronic health records, or just if that's something that you're moving towards. So just curious on that one.
Yeah. I think that's a great question. Definitely is a future, right? But you know how complicated our medical record system here in the United States. We got Epic, we got Cerner. It's just very challenging to standardize. But that's a good question. So the compromise plan will be more like, okay, may not be two systems talk to each other. It's more like this is CMS required to gather. So it's easy for data collector to get, so we will include those information in the database. For example, they start to ask a lot of, like health literacy question, be incorporated to the medical record system. So that's just a kind of a few for convenience. That's get that information as well. But it's not much like we talk to each other and you can just import data there. We are not there yet just because these are so different across centers.
Thank you. We're starting in Canada, so yeah, it'd be always great to keep in touch like we do with our experience in Canada and yours to be in the US as we move to sort of this pulling of the data from the systems.
Right, that would be great, right? You are kind of in one place, your data, it's kind of like a VA system, right? VA, they're all housed in one system. So it's relatively easy, to grab the data and populate it. So, it's challenging for us to do that.
Great question. Great question. So I see that our time is just about up. We do have one last question, I think, which is probably a very quick one. So let's see if we can squeeze it in before we end things off. So Heather in the chat was wondering if there is an estimate of the percentage who declined consent to the registry. I don't know if you know that offhand or not in terms of the percentage decline.
So, okay, I don't think you mean registry data set. You mean just overall decline to be enrolled. I think our target rate is 80% enrollment rate. So that's our benchmark. So in the past, we probably close to 90% overall. We have very few refusal in terms of people who met the criteria and agreed to be enrolled. So 80% is our benchmark. So we're probably close to 90, probably 85 in between. But recently, after COVID, for some reason, it's just not as good. That's another issue we like to address too. Follow-up rate is not as good as well. People just tired of research or being called or very interesting.
I see. Very interesting. Okay, so thank you, Dr. Chen, once again for such an amazing presentation. And thank you, everyone, for participating today. Just a note that this will be the last Jousse lecture that I will be facilitating, but moving forward, it would be Dr. Marquez Chin who will be leading the charge for future Jousse lectures, and there may be some changes coming as well. So very excited to see the evolution of this lecture series. So once again, thank you, Dr. Chen, for such an amazing talk, and I thank you, everyone, for participating today.
Thank you so much. All right. Have a good day. Bye.
Okay, thank you. Bye-bye.